Hello and welcome to a short presentation on Area9 and on the platform called Area9 Rhapsode. First and foremost, a quick introduction of myself. I'm Khurran Jamil, educated a medical doctor from Copenhagen Medical School in 2001. I later was the medical director at Lidl, and I also co-founded Area9 in 2006. Our mission is to become the world's leading learning company that at scale delivers real educational outcomes, but validated by a scientific approach. So making sure that there's evidence for the various features and capabilities that are delivered in the learning platform that I'll speak more in depth about today. Our history and our roots are deeply rooted in medical simulation. So the first 10 years of our journey were developing medical simulators, both full-scale systems and what at that time was coined medical microsimulators. Those were developed and sold as microsim in hospital, pre-hospital, and also later through American Heart's HeartCode product, where you see screenshots of those in the first part of the presentation. Later in 2006, when we started Area9, we worked with McGraw-Hill, and with them took part of a long journey of bringing analog textbook content, classic textbook content, to not only ebook and digital learning products, but adaptive learning products. I'll come back to what adaptive learning is. One of these products were marketed under a smart book, and more than 30 million users have used and access these kinds of technologies. And lately, we have partnered with a number of medical content partners. Amongst them is the NEJM group. That's the group behind the New England Journal of Medicine, where we power their CME and maintain a certification product called Knowledge Plus that thousands of physicians globally use for continuing medical education. Journal of Bone and Joint Surgery for Orthopedics. It's called Clinical Classroom. And with Time medical publishers out of Germany, global medical publisher, we're working in the area of medical students to prepare them for the USMLE and other areas of nursing education with some of their content and products. And lastly, but not least, we recently, last year in October, relaunched HeartCode with true adaptive learning underlying the HeartCode certification product in ALS and BLS, and that's also being used widely globally. So adaptive learning, what is it that in essence? Think about the best teacher or instructor or professor you've ever interacted with. What is it that teacher is really good at? There will be multiple things, but for sure, one of the things is that they are very good and active listeners. So they sense where you're weak and where you are strong. And that is what the computerized adaptive learning systems recreates at scale. So it doesn't replace a teacher or an instructor, but in the lack of that person to deliver that education, when you are on your own, when you're doing self-learning, it emulates that personal tutor-like experience. Through that, where you are focusing on the weaknesses and not the strengths necessarily, we have shown on and on that we can reduce the time to proficiency, the time to that the learner is mastering the content with up to 50%. We do this by fully closed loop learning, where we constantly check that the learner is understanding through self-assessment, through various other techniques from learning science, to make sure that that learning sticks, and that we also know when is the best time to refresh that learning. So that could, for example, be days or weeks after you've done a course where you do what's called adaptive refresh. So we can nudge or notify the learner that there's certain parts of the learning that you should readdress. This way, you really not only make sure that the learner gets up to 100% proficiency in a course, but you also maintain that knowledge over time. Thus, adaptive learning is gaining more and more widespread use for lifelong learning. And then coupled with that, you can integrate it with skills-based trainings and also other kinds of activities and in-practice exams that is very common for example, residence training and other healthcare professional trainings where you need to also do summative tests. So the approach of adaptive learning is a formative one, so you do continuous assessment, but the system that we've developed also allows you to provide tests. Now, the formative adaptive learning, how does that look? This is illustrated with these 3 real learners from a real course. What you see here is that every learner has their own unique path from A to Z, but all of them, they become 100% proficient. So that means that they master the content. They take from 8 to 33 minutes, and they also have different unconscious incompetence profiles or metacognition profiles, because it's metacognition, this part of figuring out what does the learner know about their own strengths and limitations. Learner 2, in this case, is showing up to 41% of the times that he or she thinks that they know the subject, but in reality they don't. Learner 1, only 3%. So whether this learner took 19 minutes or 8 minutes or 33 minutes, learner 2, the bigger challenge and the bigger risk for potential human error is with learner 2, because often this learner thinks he or she knows it, but they don't. And we need to resurrect that. And the system helps the learner to become consciously competent, which is the goal of the training. So 100% proficiency, and as much as anyhow possible, consciously competent. This way, you can bring a whole organization, a healthcare organization, whether it's nurses, doctors, or other allied health professionals, from a state of potentially quite a lot unconscious incompetence in the lower left quadrant, through deliberate practice and training, to the upper right quadrant, to conscious competence. We have seen this across many healthcare domains. This is data from more than 3,700 learners, pediatricians, residents, where you see the blue area is the initial unconscious incompetence that we have extracted data on, where the average is around 24% of the time when they're presented for a case. They are handling that case by saying that this is how I would do it, but in reality that's wrong according to the guidelines or the best recommendations. Over a couple of months, we have brought that down through deliberate practice and training to a significantly lower level, to around 15%, as it can be seen by moving the blue area to the left. That's the yellow representation of all the learners. The number of learners is over here, and percent unconscious incompetence is down here on the x-axis. Not only are we reducing or potentially eliminating unconscious incompetence in certain cases, we are, as I mentioned, also reducing the time it takes to become 100% proficient. So this is an illustration from, again, real data, around 1,000 learners, where an existing e-learning course in a classic LMS were taking on average 45 minutes. We have reduced that to an average of 23 minutes, but more importantly, we leave no one behind. Everyone succeeds here, as seen with the graph. And putting all of this into perspective, to summarize, we can say that adaptive learning is fantastic to cover the knowledge domain in this framework that we call 4-dimensional education, where you can let the computer to a large extent take care of the knowledge domain, and let the instructor, the teachers, the professors of the other important domains of becoming 21st century learners. So the skills domain, which covers creativity, critical thinking, and also psychomotor skills, that typically is done in simulation centers all around the world. So allowing individuals to focus more of their instructor time with the learners on the skills, and potentially also the important area of character around developing mindful, curious learners, resilient learners, and then let the knowledge domain be carried out by more automatic tools such as adaptive learning. Finally, meta-learning is this shaping of people's ability to reflect over where they have weaknesses. And when you strengthen that, you also de-risk the chance of human error, because people will be more conscious about their knowledge level at any current stage. So how can this look if this was deployed in a healthcare system? This is an example of a learner dashboard. So Stephanie, in this case, it could be a nurse or doctor. Today, she can interact with some learning courses on vaccination. That's the learn part. And she may also have a test on COVID-19 that she needs to show that she knows how to handle COVID-19 cases. That's the exam part in the middle. But a course that she took some weeks ago on ethics has popped up on her screen in order for her to refresh and make that learning she did stick. She can also communicate in the lower left corner with Peter Thompson, which may be her professor or fellow colleague, to communicate around a new medical healthcare finding. She can check her transcript. How is she doing on her competencies? So there is a whole competency system built into the platform as well that allows for checkoffs of certain competencies. On top of that, the various certificates that are mandatory, they are also being tracked here. And more open-ended things such as writing potentially a short essay, things like that is also available in the platform. The platform, Rhapsode, is device agnostic. So it works on computers, on phones, and on pads, tablets. And as you can see in the lower right corner, you can also, as I mentioned before, integrate skills-based simulations and even VR if that is a need. And those advanced parts, again, are there to be integrated so that we can look at the learner from a holistic four-dimensional framework where knowledge, skills, character, and data learning constantly is in focus. We also allow, besides delivering adaptive courses, to do federated search. So you basically, federated search is searching across all the kind of content you would like your healthcare organization to have access to. So let's say today that you have access to a number of courses that are classic e-learning or videos, materials that are not powered by adaptive learning. The platform can also house that, and it can be searched, and you can have learners consume content in a more classic manner as well. This way, you are able to build what we call blended learning pathways. So as an organization, a hospital system, a hospital department can, together with us, build content from various sources that you may already now have access to, YouTube content, generic content from some of our partners, and also adaptive foundation content with partners such as NEGM Knowledge Plus, where there are a multiple of products available on the market in internal medicine, family medicine, pediatrics, and airway management, and orthopedics. And we are also bringing about other areas constantly to the market where content that is not adaptive today is being transformed to adaptive content. So you can combine generic content that is not adaptive with adaptive content. And then let's say a hospital is in need for hospital organizational specific content, that is some content that the hospital has developed themselves or want to develop. We can then partner around that and build that also adaptively or house it in the platform. This way, you can build a whole academy that covers the needs of students, residents training, interdisciplinary training, including with nurses, and continuing education, combining the power of the platform with the power of content from our partners with the content of your own. One big aspect that we have learned, of course, during the pandemic is that communication has become vital. Asynchronous communication and synchronous communication. So the asynchronous, the communication you can do through chat, through email, and other means is also available and embedded in the platform. So you are able to communicate with a group of residents, a group of nurses, and actually provide various training content, knowledge sharing through a functionality called the communicator. We also have a specific developed learning calendar that only houses the training events. That could be in-person training events in a simulation lab. It could be virtual sessions with a professor or teacher, or it could be your regular assignments that you need to do as an e-learning, either adaptive or non-adaptive. The video functionality that we all have gotten used to is also embedded in the platform. So we integrate with Zoom, with MS Teams, or WebEx, or our embedded video system if you don't use Zoom, MS Teams, or WebEx. That allows instructors, professors to schedule one-on-one coaching, live coaching, streamed sessions as well, and group learning. All of this allows the teacher, the facilitator, ultimately to deliver a flipped classroom experience, because you can get all the data on where are the learners lacking knowledge, or where are their knowledge gaps, and based on that you can then set the various assignments and then follow all the learners in your organization. and receive early warning analytics on and who is at risk for falling behind because they are either struggling with certain learnings or they're not completing potentially mandatory trainings. The kind of data that can be collected is enormous. One of the key differentiators of this platform is that we collect a lot of data on metacognition, this aspect of unconscious incompetence. Not only who is unconscious incompetence, at what degree they are, but down to the granular learning objective, what particular content item is a certain learner struggling with. That's just one of many content analytics and learner analytics data points that you receive. We also allow in the system for teachers and instructors to create their own curriculum, basically build and share own content. And that content that you create yourself, you can also share that with other educators. So there's a whole system that allows for simple content creation for an organization. This is a part that if you deploy Rhapsody, the platform, we provide the training to educators that wish to not only use off-the-shelf content or custom content that we have created for your organization, but you also want to create simple questions or simple resources that will also then be available in the platform. Lastly, because we know we operate in an environment with a lot of other systems, we integrate into the learning ecosystem that you currently have, whether that's Moodle, LMS, or Canvas, or any of the various LMS or learning platforms. We know that we need to live in an ecosystem that you've already bought into and are potentially happy with. This part of the webinar, I've invited our Chief Clinical Advisor, Dr. Mark Berg, professor at Stanford, and also Area9's advisor. And I would love to have a casual chat about certain of our partnerships where Dr. Berg has been helping oversee the medical development and also implementation of some of the programs. Initially, when I started the webinar, I shared some of the partnerships that Area9 has had over the last 20 years, notably the New England Journal of Medicine group partnership, where we've developed NEGM Knowledge Plus with them, which we briefly touched upon in the webinar, but also the RQI partnership, which is the joint venture between American Heart Association and Leardale Medical. And we will dwell more into the HeartCode program in a moment. But first and foremost, thank you, Mark, for joining.
Of course.
A few words on your background, and then we can start to talk a little bit more about HeartCode.
Great. Yeah, great to chat with you about these activities. As you introduced me, my name is Mark Berg. I'm a professor of pediatrics at Stanford University. I'm in Palo Alto this morning. And additionally, relevant to this discussion, I have been an American Heart Association volunteer for over 10 years, and I led the Paediatric Advanced Life Support course back in 2010. To round out the picture, of course, I'm Chief Clinical Advisor for the Area9 group, and so I have a hand in production of anything related to healthcare and education with Area9. So yeah, happy to sort of have a little deeper discussion this morning.
Great. So there are two main products from HeartCode for physicians: HeartCode PALS, Paediatric Advanced Life Support, and HeartCode ACLS. So Mark, from your point of view, compared to, I mean, you've been with AHA for so many years. You mentioned the 10 years prior to this period where you were chairing the pediatric resuscitation team.
Yeah.
What challenges when it comes to the way that certification was done, let's say 15 years ago, has overcome using advanced e-learning programs in your view?
Well, I think first and foremost would be the speed and efficiency with which we are now able to deliver this educational content. So let me explain a little bit more. Back in 2010, when we had the guidelines release, and also in 2015, where I was involved in AHA guidelines as well, the time between the release of the science and the actual release of the educational material for pediatrics was a year or more. And so having been a volunteer there for so many years, that was always a a source of discouragement. All of the science volunteers and educators wanted to be able to do that more quickly. So, Khurran, as you'll remember, last year in 2020, with guidelines release, working with the Heart Association through RQI partners, we were able to release the new HeartCode using Rhapsode Adaptive Learning on the same day that guidelines were released. So that's a first. That's a first for the Heart Association, and a first anywhere to my knowledge. So I think that was a big achievement.
So how did AHA and Area9 and your team turn the traditional, so to say, HeartCode e-learning content into adaptive learning? Can you talk a little bit about that process as you were deeply involved in that?
Yeah, sure. So of course we worked with our partners at RQI, American Heart Association, and Laerdal, and their subject matter experts in this material. And we did what we do with all adaptive learning products, which really is different than a traditional approach. And that is, we made incredibly granular learning objectives. So for example, in a 45-minute exercise, traditionally you may have 4 or 5 learning objectives. But for us, using Rhapsode Adaptive Learning, we would have 25 or 30 learning objectives for the same material. So once we go through and really catalog all of the very focused and detailed learning objectives, then we can work within Rhapsode and create the content that addresses those objectives very specifically. And most importantly, we create what we term as probes, which is the way to interact with the student and really confirm their knowledge of the subject and their competency. So that process plays out over weeks. Although with such a great team and great partners, we're able to move quite quickly and create these products. I think we did it in a matter of 2 or 3 months, if I remember correctly.
Both the ACLS and the PALS.
We had a good team. I mean, the primary focus is to make sure we have excellent content, which of course the Heart Association provides. And then on the adaptive learning side, on the Area9 side, we have a very small but expert team that's focused on quickly creating this content in Rhapsode and being able to revise it and get to production.
And what would you say, kind of moving a little bit ahead, what are the kind of benefits of moving to an adaptive learning approach, in this case for HeartCode, for the hospitals and training centers, instructors, and the students, in your view?
Yeah. In my mind, the single best advantage is that it's really twofold. One is the efficiency. So I think perhaps in other aspects of the presentation, the participants have seen the advantages in using adaptive learning for efficiency. So we have mountains of data from millions of student interactions or at Area9 that shows that a typical educational activity, e-learning of some sort, if you will, using Rhapsode Adaptive Learning is probably 40% and more efficient. So in my mind, yes, and you can see the slide here, that really demonstrates it nicely. The red dotted line would be a traditional course, and in adaptive, we're seeing the green line. And all the gray lines heading towards 100% really speaks to the second part of what I think is the advantage, and that is assurance, 100% assurance of 100% competency in the material. So a traditional course, you perhaps answer a few questions, or maybe you don't even answer any questions, you just passively watch some content. And actually we as the teachers and the students also have no real way of knowing their competency level. Contrast that with working in Rhapsode and using adaptive learning, we guarantee, because we have it we have it graphically displayed here. You can see each student achieves 100% proficiency by the end of by experience. So the two things: efficiency of learning and speed, and also guaranteed competency.
So this hugely efficient methodology, could the AI, the artificial intelligence behind these algorithms, potentially over-evaluate the learner's proficiency level? Like what safety mechanism would let's say, instructor or hospital have that Khurran and Mark are not, that they are really 100% proficient and not overconfident, or how would the system help with that?
Yeah, that's a good question, and it really speaks to one of the core tools within Rhapsode, and that's this concept of metacognition and the concept of really self-reflection by the student. For each and every interaction with Rhapsode, the student is asked to rate their confidence in the material. So the power and the beauty of that is it helps identify students who are underconfident and need to just improve their confidence as they learn. But in healthcare, very importantly, it identifies the students who are overconfident. and perhaps believe they know the material when they may not. And so I think, at the professor level or as an educator, for me, that's really so reassuring to be able to see that whole range. And we see this on the screen now. You've pulled this up as we're talking. This data is actually from pediatric physicians from our work with the New England Journal in New England Journal's Knowledge Plus program, which uses Area9 Rhapsode as its adaptive learning platform. And you will see unconscious incompetence. The initial unconscious incompetence is the blue, and then you see the improvement in that. In other words, shifting to the left here in the yellow. I think what was most striking for me is that you'll see the number there, approximately 24% of these physicians actually did not know what they did not know. They were not aware of their knowledge gaps. And keep in mind, these are not just average students. These are professionals. They're pediatric physicians who have completed their medical education, and still almost 25% of the time they had these knowledge gaps. And so that's probably the third leg of the beauty of using adaptive learning: the efficiency, the guaranteed competence, and then also rooting out and identifying for the student what they do and do not know.
So for the webinar attendees, all of this data is actually available for potentially available for instructors and kind of those who manage, let's say, residents or fellows or the trainees. And with that data, Mark, what would you say potentially? Let's just talk generally. This is data from a product from NGM Knowledge Plus. The other one is the HeartCode, which is obviously in another area of training. This kind of data, for those hospitals that have large simulation centers or simulation-based training where you do face-to-face training, what would you imagine, what would you suggest that adaptive learning courses, where do they fit? And where does the data, what can the instructors, the simulation instructors use that data for? What would be the ideal flow of using adaptive learning with simulation?
Well, our discussion up until this point has really focused on the student and the benefits to the student. There's a whole other side of that equation, which is really the benefit to the organization or the benefit to the professor, if you will. And in my mind, it's having this data as a teacher myself for now almost 25 years in academic medicine. I've never been able to gain this kind of insight into a specific student when I zoom in, or I've also never had this insight on a class or population level when I zoom out. And so what I mean by that is individual students that I'm responsible for, I can see exactly where they're struggling, where they're succeeding, and follow their progress. And then as a teacher, of course, adaptive learning is best as an augmentation to other types of learning. I'm hopefully not going to lose my job at the university because of adaptive learning, but actually it enhances what I'm able to do as a teacher. So with an individual student, I can follow their progress. As a professor, I love to be able to see the whole class, whether it's 50 or 100 or 5,000 or 50,000 students, because I start to see the whole landscape of my educational material. And for example, if I can see a learning objective where a high percentage of students are unclear initially, that gives me an opportunity to go back in and perhaps revise or focus those learning resources or how I'm teaching that material. So, and here now on the screen, you're seeing some of what I'm talking about. You get incredible insight, both at the student level, which you would see on the left side of the screen here, the progress at red, yellow, and green, but also on the larger macro level for course development.
Yeah, so we've of course anonymized the learners here, but the grayed out are the learners. So, and one other highlight, other than the metacognition level in general of this, let's say it could be a simulation class where you could do a flipped simulation room, not a classroom, but a simulation room, right? Where you could get red flags on which learners that are to participate in the simulation may lack some knowledge or some area of the cognitive portion that you need to apply in the simulation. Like theoretically, at least Mark, we've been talking about this for years. Like I've been giving presentations about flipped classroom and also talked to a lot of healthcare systems around this. What barriers do you see as a practicing clinician as well, and running simulations in applying something like this in healthcare system? What would be the practical implication? Because the systems are there, the simulation tools are there, simulation centers are there, the instructors are available, adaptive learning platforms are available, content is available. What would be your best advice to, let's say, someone who's heading up a simulation center?
Yeah, this part I think is still just wide open, and people at the leading edge of these technologies. There's still so much that we can do here. So let me give you an example. If you've attended a lecture, hopefully with a good speaker or good professor or presenter, very often they'll start out with a few questions. How many here are nurses? How many here are doctors? How many people here have ever seen a patient with COVID infection, for example? What the professor is doing is trying to gain some insight into who the audience is. And really, in real time, they're going to craft their presentation to try to meet those specific factors. What we have here, your question to me is really about the marriage of adaptive learning and simulation. What we have here is a tool that is so much more powerful than just a few questions at the beginning of a lecture. I, as a professor, would have the opportunity to create a focused adaptive learning module, for example, before a simulation exercise, and have the student participants take that module. It would accomplish two things. Number one, it would level up the students, and we would know that every student entering the simulation room would be confirmed to have an understanding of the cognitive material, the core material. But again, it also, from the professor side, would give me great insight into where those students collectively had some difficulty. And I could tailor the simulation to that specifically. So the reason I say this is still wide open is because technology yet, I don't know anyone in a simulation lab environment or in a simulation center who's really marrying adaptive learning to the real world full-scale simulation. I'm excited to do it here at Stanford, and we're just starting to dabble in some of that, but it's wide open, and it's frankly, it's exciting.
So when it comes to research in educational research in simulation, I guess you can share a little bit about, we've come some way, right, over the last 20 years. And I think if you want to share a little bit on that, where we are, what's the status on proof of simulation, and I'll cover a little bit on adaptive learning as well. But the goal would be really to do combined research on both simulation and adaptive, right?
Yeah.
Could you comment a little bit on the developments over the last 20 years on the science part and research part of these teaching tools?
Yeah. Well, the amount of scientific inquiry and research into simulation as an educational tool has just taken off in the last really even 10 years, and it's ramping up every year. So if you went back 20 years and looked for scientific publications on simulation science, there were very few, and now in health, taking off. I guess. One thing I think, again, which is really an area for focus, is the understanding that it's not just being in a simulation in an expensive, high resolution, full scale simulation. There's nothing necessarily magic about that. I know we love our simulation centers and we love creating these simulations, but really it's just another tool, and like it should be used best for best effectiveness. So when the science right now is, and there's good science to show that, the educational is really won and lost in the realism scenario and the accuracy of the scenario, and also in the debriefing. And so if you take students who are not ready, they're not ready to be in the simulation environment, and just think that magically they will have the best experience because they're in a simulation lab, that's probably not true. I like to say that our simulation centers are sort of like the Ferrari of the education world. They're very expensive, they're very fast and powerful, but if you're learning how to drive, you don't take your first shot with a Ferrari at the racetrack.
Yeah.
So
good analogy.
Yeah, so let's use adaptive learning, which is a great way to make sure we all understand the content and really get our driving skills great. Then when we go to the track and we're in the Ferrari, we can really maximize our time. Teaching a student something very basic in a complex simulation facility is probably not the best use of the simulation facility or the student's time. But again, the marriage of those two, adaptive learning upfront, simulation, and then return to adaptive learning, complete the cycle, take what we learn in the simulated environment, put it back into Rhapsode so each student can follow through on their own progress. To me, that's where the future is going.
Fantastic. And I have on the screen a few of the kind of articles. These are based on NEJM Knowledge Plus for both for continuous lifelong learning for internal medicine doctors, pediatricians, family medicine doctors. This particular article is the Association of Use of NEJM Knowledge Plus on the performance on the American Board of Internal Medicine maintenance certification exam that showed significant a higher pass rate, more than 10%, a greater likelihood of passing the IBM exam compared to using other preparation tools. So this is just one of several papers. And I have a few other screen grabs of those articles here. And these articles can be found obviously on the internet, but NHM are offering through a link to download a white paper about adaptive learning for the 21st century. And this is residence training insights and best practices. I'll encourage you to either reach out to us or to NEGM Knowledge Plus. On Area9's own website, we also have started to gather the evidence that is becoming available. The research done by third party, of course. And Mark, you are hopefully over the next years also going to share new research coming from some of the work that Stanford University is doing in Africa around saving children's life with better training of nurses. Maybe you want to finalize this webinar with a little bit of that, if you may, what you can share.
Yeah, of course.
That's outside, again, something you're doing with Stanford and some professors there.
Yeah, I'm happy to. Putting on again now another hat as researcher. I'm working with some colleagues at Stanford, as you mentioned, in a project to train healthcare workers in Botswana to recognize sick and injured children. And as many people know, just identifying a sick child early is often the difference between life and death for that child. And so really, more than a medical problem, that's an education problem. And we have really well-intentioned healthcare workers, healthcare providers in every country of the world, but especially in the developing world, that the tool they need is understanding and knowledge and to recognize that sick child. So we're currently enrolling subjects, healthcare workers in Botswana in this study that I'm doing with colleagues here at Stanford in the Global Health Department, and we will plan to publish that data in 2021. We're enrolling, or 2022. We're enrolling right now in this study. Here you see this Helping Children Survive Collaborative. For me, it's been just wonderful to, again, really bring it full circle and combine all my interests: simulation, education, pediatric medicine, and put it all into one. So it's been wonderful. I look forward to sharing those results when we have them.
That's great. So that's the work with Dr. Peter Meany, and this is a small blog where we posted this last year, I believe. So we'll be interested to follow this and support this, and I hope that this part of the webinar was useful to give some insights into both HeartCode, NEGM Knowledge Plus, and some of the other works that we are doing around the world, where Rhapsody is the base platform to deliver more efficient and the 21st century type of learning. Dr. Berg, thank you a lot for joining, and hopefully we will get more sessions like this in the future.
Yeah, I welcome it. As you can tell, I enjoy this, and I'd welcome the opportunity to chat with any of my colleagues, any colleagues that want to discuss it further.
Right. The last part before we finish is experiencing adaptive learning. You can go to Area9 Lyceum's website. I'll show you where to go. And under the second last banner, you can go under case studies and read more, or under industries and see under healthcare our experience. And depending on if you're a hospital, a medical clinic, a life science company, or an association, you can then see the various cases and backgrounds that I've also mentioned today. And if you want to try out a product, you can go under collections and sign up for free to certain free courses that we've made available. One of them is this COVID-19 updates to emergency cardiac care from American Heart Association. If you click, and then you will go and you can register for how to quickly get updated on the latest guidelines. If you are in the laboratory medicine world, there is a product for lab medicine as well. And that's a very comprehensive library of content that's free for individual subscribers. It was previously $89 a year. We made that freely accessible to all learners. I'll strongly encourage those of you who are in this area or interested in experiencing it to go to the Learning Lab site, where you can look at all the various courses in clinical chemistry down to transfusion medicine, certain topics, and see what's available and register. When you register for one course, you will be accessing all the more than 80 courses that are on the platform. I hope that this was a basic introduction, and if there are more questions, we will of course be happy to answer any questions.